Good afternoon, everyone. My name's Greg Shaw. I'm the Director of International and Corporate Relations at the International Federation on Aging. Today, I have the great pleasure of moderating this webinar on frailty and older adult vaccine effectiveness, presented by Dr. Melissa Andrew. This webinar is part of the IFA's larger celebration for the International Day of Older Persons, which this year focuses on the theme, the journey towards age equality. In celebration of this, with the critical nature of life course approach to immunisation as a critical component of the universal healthcare agenda. Today's keynote speaker is Dr. Andrew, an Associate Professor of Medicine and Consultant in Geriatric Medicine at Dalhousie University in Halifax, Nova Scotia, Canada. She completed her MD as well as residency training in internal medicine and geriatrics at Dalhousie University. She did a Masters of Public Health at the London School of Hygiene and Tropical Medicine on a Commonwealth Scholarship, then returned to Dalhousie to complete her interdisciplinary PhD on frailty and social vulnerability in older adults. She is an associate member of the Canadian Centre for Vaccinology. As part of the Canadian Immunisation Research Network, she is a co-principal investigator of the Serious Outcomes Surveillance Network, where she studied how frailty impacts vaccine effectiveness and critical outcomes of vaccine preventable infections in older people. She also serves on the scientific and executive committee of the Global Influenza Hospital Surveillance Network. Before I hand over to Dr. Andrew, I want to mention to you that today's webinar, the IFA will be hosting a side event, apart from the webinar today, we'll be hosting a side event at the United Nations headquarters on the 11th of October as part of the IDOP celebrations this year to continue celebrating that particular initiative. This event will focus on older adult influenza vaccines and will feature international professionals in the field of patient health advocacy, health economics, and medicine. If you're interested in attending, please register for this event by registering in the events title in the search bar. Registration is open until the 30th of September at 6 p.m. If people have got questions about it, at the end of this presentation, you can always email Nicole and she can provide information about that registration. The other thing that I want to mention, people will see at the bottom of the screen, there is a button for Q&A. If you have questions where you're looking for answers throughout the course of this webinar, please pose your questions there. And at the end of the presentation, I will moderate some, if not all, of those questions back to Dr. Andrew. So with that, I want to hand over to Dr. Andrew and thank you for sparing your time today as well, Dr. Andrew.
Thank you very much. I'm just putting my slides up. Hopefully you see them now. Perfect. So it's an honor for me to be presenting this webinar today on such an important topic. I hope you all find it useful, and I'd be happy to engage in questions at the end. So just for disclosures, the work that I'll be discussing is funded by grants from various different sources, including in partnership with industry as well as public funders. And I've had travel and honorarium funding from the groups that are listed as well. So I wanted to start out with the key points, just to see where we're going to be going during this next 45 minutes or so. So what I want to convey is that frail older adults are at increased risk for influenza and complications, but that generally speaking, vaccine responses are lower. And so we really need to be thinking about frailty when we study vaccine effectiveness. The second point will be that the burden of influenza is usually something that we think about in short time horizons. So the mortality and morbidity at the time of the acute illness. But in the case of older adults, we really need to extend our thinking to be thinking in longer time horizons, such as persistent functional declines that lead to need for home care or long-term care. the third point is that older adults may not present with the classic symptoms that we think of as being associated with influenza or, in fact, with any illness, which has implications for how we make diagnosis and do surveillance. And then the fourth point will be to think about what different vaccine products are available for older adults and which ones are recommended by different advisory bodies. So I'll start out, though, with a discussion of what frailty has to do with influenza, because you might be wondering, why are we talking about this in the first place? So first of all, frailty is a bit of a tricky concept because it's something that we all would come to from a different point of view. So people have associated different meanings with the word frailty, and of course we use it in general conversation and in literature in different ways. So when I talk about frailty, a useful definition is this one, that it involves increased vulnerability to adverse outcomes or to bad things happening after a health insult, such as is demonstrated on this graph. Now, if I use my pointer, I'm not sure if that shows up on your screens, but the point is that the dotted line on this figure really shows the threshold of independence. So if somebody's above that line, they're independent, they don't need help with their daily function. Whereas if they're below it, they would be needing help with their daily functions such as home care, long-term care, or relying on friends and family. So somebody who is fit and not frail would be more like the green line above. They'd be quite robust. They're not on the edge of a precipitous decline in function or of losing that balance. And if they have a minor illness, or even a more major one, such as influenza, they would take a dip in their function at that time. But it would generally not put them down below the point where they need significant assistance in their daily life. And then hopefully they recover relatively quickly from that back to their prior baseline. The challenge is for someone who is teetering a little more on the edge of needing help at the best of times, if they have an additional health insult like influenza, they can really take a much bigger dip in their function, such that they then need help in their daily activities. And the recovery from that can be much more prolonged, and they may never get back to their prior baseline. And so the important thing there is where that red line ends up. Is it above the threshold such that they can manage at home again, or are they below it so that they need a lot more help in the long term? And this recovery is really important to older people. When we talk to patients and also in research studies, they don't only care about survival. They do care about their quality of life. And so it's really important for us to be thinking about that as well. So that's the general idea of what frailty is. There are different ways that we can measure it, which we'll get to a bit later. Now, another important point here is that the immune system changes with aging. So that the and I'm no immunologist, so I'll simplify this quite a lot here. Essentially, the immune system functions in different ways. So there's some of it that's called innate or has no particular memory, and that has to do with the physical barriers like skin or mucous membranes, and the general inflammatory responses to any sort of insult to help the body fight it off. When it comes to the adaptive parts of the immune system, this has to do with what we think of usually as immunity, about B cells producing antibodies, and then T cells helping out with the response to the infection. Now, as people get older, there are changes in the immune system that happen. So these affect all of the different parts of the immunity that I mentioned before. So first of all, there tends to be a reduction in antibody production in response to a infection, and also the avidity or the ability of those antibodies to really bind specifically to their target may be reduced. We can also see reductions in certain aspects of the cell-mediated immunity as part of the, like the T cells, for example. And then we see changes in how antigens or bits of viruses or other infectious agents are presented and processed to the immune system. Also, there's there can be a general weakening of host defenses, such as the ability for the cilia in one's respiratory tract to bring up debris and to cough it out. And muscle strength, for example, can be affected as well, weakening the cough response. We also know that traditional measures of vaccine response, such as measuring titers of immunoglobulins and antibodies, don't necessarily correlate well with the vaccine efficacy, meaning that there have been studies looking at older adults' responses to influenza A, H3N2, for example, and it found that they had some of the studies find that the titers or the response is as good as younger people, but it may not provide as much protection. So the challenge is really that although the memory parts of the immune system provide some protection against the initial steps of infection, if the infection isn't fought off and does take hold, the immune system of an older person may have a harder time fighting it off. So all of this contributes to the idea of immunosenescence. So there are other important parts of the immune system too. So there are these cytokines and inflammatory markers that are produced in response to inflammation and also to try to counteract inflammation. And the challenge is that in the setting of this dysregulation that associated with aging, which some have called inflammaging, that balance is dysregulated. So the balance is off, leading to problems either with over stimulation and extra inflammatory responses that are harmful in and of themselves, or alternatively not being able to fight off the insults or the infections as well. So all of these points have to do with the immunosenescence and the inflammaging, which affect older people's responses to infections. So we've touched a bit about why frailty matters and how the immune system changes with age. And now we'll get back to the key points. So the first one is about how frail older adults are at increased risk for influenza and for its complications, but we need to be thinking about the impacts of age on vaccine effectiveness. So our Serious Outcomes Surveillance Network is a national effort that's been running since about 2010. Each year we have a different number of sites involved depending on the funding. And currently it's funded through the Public Health Agency of Canada as part of Canada's influenza surveillance, focusing on illness that's severe enough to land people in the hospital. This is a network that looks at adults of all ages from about 16 up. But of course, because we know that older adults are overrepresented in hospitalized influenza cases, we definitely have a lot of older adults year after year. So the methods of our network are that one way that it's been unique in comparison to other hospital networks is that we have a really important focus on these health measures and outcomes that are important for older adults, particularly frailty, also function and basic activities of daily living, and also in some seasons we've looked in detail at mobility and balance. So another key feature is that it's active surveillance, meaning that we don't just wait for positive tests to come back from the lab. We actually send our network monitors out actively looking for patients who meet criteria to be enrolled and tested for influenza. So what they do is during the influenza season each year, from about November 15th to the end of April, depending, of course, on if there's influenza circulating in the community. Outside those times, they would be doing surveillance for longer as well. What they do is identify patients who are admitted to the hospitals that are participating sites who have a diagnosis of community-acquired pneumonia, exacerbation of COPD or asthma, or unexplained sepsis or fever or infection, any respiratory diagnosis or symptom, and on some days as well, acute coronary syndromes or heart troubles with, or strokes with a bit of a fever. So these patients are enrolled and then tested using a nasopharyngeal swab. And then the swabs are sent off for PCR testing for influenza. Now, it makes sense at this point to pause and think about the abbreviation VE is used a lot in this literature, and sometimes it means vaccine efficacy, and sometimes it means vaccine effectiveness. So I'll just discuss the differences. So vaccine efficacy is what you would get out of a, for example, a randomized controlled trial that's done under optimal research conditions. And there's always objective outcomes and measures like laboratory PCR confirmation and very rigorous case definitions for inclusion criteria. And the point is that it's meant to maximize the validity of the results. However, it may not be as generalizable because certain groups of patients may be excluded, like older, frail people, for example, tend to be underrepresented in these randomized controlled trials. What we're looking at here in our clinical network is vaccine effectiveness, which is how well the vaccine works in the real-world setting. It can still have a rigorous design, ideally, again, with laboratory confirmation and specific well-defined case definitions. But it also becomes more generalizable because it's done in a real-world setting. So here we're talking about vaccine effectiveness. And in the case of a network like ours, where we enroll the patients, test them for influenza, and then we have some who test positive and some who test negative, we can compare the incidence of influenza in the people who've been vaccinated, for example, versus the people who haven't. And we use this test negative design. And this design also allows us to adjust for important factors, or alternatively, to stratify by age to generate specific vaccine effectiveness estimates by age or by frailty, adjusting for things like smoking status, exposure to influenza in the community, living with children, these types of things. So I said that frailty can be measured in different ways, and here are two that we've used in our network. So one is to use a frailty index, which is really based on the idea that as health deficits accumulate, often with age, someone becomes more frail. So the more health deficits a person has, the more frail they are, and really becomes a counting exercise of counting up all the problems that they have, and then dividing it by the total number of problems that we've considered. So the different deficits that we look at are based on the philosophy of comprehensive geriatric assessment, where we look at cognition, whether they have dementia or delirium. We look at mood, sensory function or impairments in speech and vision and hearing, for example. We look at their mobility and can they walk by themselves, transfer by themselves, do they need a walking aid, have they had falls. We look at their nutrition and weight, and importantly, we look at their function in activities of daily living, whether they need help with those things, and also their continence. In addition, we factor in chronic medical conditions and medication use as well, and arrive at a frailty index, such that the higher the frailty index value, the more frail or the more deficits the person has. So the other way that we've measured frailty in our network is using a much more brief yet clinically relevant scale called the clinical frailty scale, which is shown here. And in this scale, everybody fits into one of these categories, from the very fit marathon runners to the people who are severely frail, dependent in all of their activities of daily living. And this is based on a general assessment that the network monitor would have from the best available sources, including talking to the patient, reviewing the records, speaking with family and other clinicians. So those are the two measures of frailty we've used. So getting into some of what we've been finding. So one thing that we see is it's interesting to compare stratification by age to frailty. So traditionally, we've thought about age. So it's quite common to say, are people over 65 more prone to adverse outcomes, for example? And here we see that, that the people in the over 65 age group, and indeed even older, over 75, are in fact more likely to pass away from the influenza once they're in the hospital. As you see there, from the youngest adults, the mortality was about 4.5% up to 14.4% in the oldest group. Interestingly, though, we don't see any difference in how often people go to ICU, and in fact, it's not the sickest people who necessarily go to ICU. In fact, they may be the oldest ones who do die, but they don't end up being eligible, perhaps, or making it to the intensive care unit. So ICU use doesn't turn out to be as great a measure of severity in our population as it might otherwise be, just because of this issue that the goals of care for the patient may not include going to the ICU. An important point, though, to focus on is the top pie charts here. So we know that vaccine uptake is suboptimal in all of our adult age groups, and certainly we see it here. Although what we do see is that as people get older, they are more likely to have had the influenza vaccine. Now we'll look at the same sort of results stratified by frailty. So with regard to vaccination, as people get more frail, they're more likely to have the vaccine. And this may have to do with having multiple chronic conditions, having more clinicians recommending it, having gotten the message over time that they should have the vaccine in particular because they are in a high-risk group, even though potentially many of them might be in the high-risk group of being over 65. But what we see is that the gradient of mortality is more apparent when you look at frailty than it was even with age, right? So amongst the fittest people, we find that mortality is lower, about 3.2%, whereas in the moderate to severely frail people, their mortality was about 23%. Similarly to the previous story, though, ICU admissions doesn't track that well with frailty because even though the frailest people might be the sickest, they are less likely perhaps to go to the intensive care unit. So part of the point here is that because there's a difference in the propensity to be vaccinated, it's important to take, by frailty, it would be important to adjust for that when we're thinking about the effectiveness of the vaccine. So we published a paper based on one of our influenza seasons where we looked at how adjusting for frailty affected vaccine effectiveness estimates. And you can see in this case, we used the frailty index only for the people over 65. So the bottom line in that table. And the unadjusted vaccine effectiveness estimate was 45%, meaning that it was 45% effective in preventing influenza that was severe enough to end up in requiring hospital admission. Whereas when we adjusted for all of these confounders, including admission from a nursing home, exposure to children in the household because they do tend to be little vectors of infection, smoking history, and medication use, we found an adjusted vaccine effectiveness of 58%. But interestingly, when we chose to only adjust for frailty as the single confounder in the model, was very closely approximating that. So from that, we take that frailty really seems to be the most important confounder to take into account for older adults. Now, another way to look at this is to see how vaccine effectiveness changes with frailty, because we've got this message that's out there that older adults don't respond as well to the vaccine. But what we asked was, well, does the frailty matter? So do fit older adults respond well to vaccine, but perhaps the vaccine effectiveness tails off as they become more frail? And that's indeed what we seem to be seeing. So as you'll see here, the vaccine effectiveness was quite high, in fact, in that year, 77% in the fit older adults who are represented in blue. But once we got up to the frail ones, it reduced to some degree, and the most frail, the vaccine effectiveness was negligible. So an important point to keep in mind is that most older adults are not frail. So the prevalence of frailty is about 24% or so in community-dwelling older adults. And it's important as a message to say, well, you may well, if you're a non-frail older adult, have a very good response to an influenza vaccine. On the flip side, we also need to recognize that the most frail people are at highest risk from influenza and complications. So we definitely still recommend vaccine for them. We just have to be thinking about it in a bigger picture, which we'll get to at the end. So another question that comes up is whether or not vaccine effectiveness is always worse in older adults. And it's become evident to us through analyzing different seasons that that's not always the case. So here, for example, is pooled vaccine effectiveness across 3 different seasons, where we have quite a number of patients involved here, 3,300 cases and 4,500 controls. And what we found was the vaccine effectiveness, this is adjusted for the relevant confounders, was nearly as good in older adults as it was in younger adults. But in fact, the vaccine effectiveness against the most severe outcomes, including death, was higher among the older adults. So really the take-home point is that vaccine effectiveness does vary by age and by season and by strain and by frailty and by outcome. And though that the story is not always so clear that it's always worse in older adults. Here's another season as an example. So we looked at the burden of disease and vaccine effectiveness estimates in the 2017-18 season, which was quite a significant influenza season in Canada. During that season, we had over 2,000 laboratory-confirmed influenza cases in our network. And the predominant strain was this influenza H3N2, which does tend to be more serious for older adults. Indeed, in that year, we found that over half of our enrolled patients were over the age of 75, really demonstrating the burden of illness in that age group. Interestingly, we also found that vaccine effectiveness was as good or better in older adults compared with the younger adults. Of course, in the younger adults there, the confidence intervals are wide, partly because there are so few of them, only about 24% of the sample. When we looked at outcomes stratified by level of frailty, what we see is that the length of stay in hospital, of course, tends to go up with increasing frailty. And mortality certainly goes up with increasing frailty as well. But we see the same pattern I discussed earlier with the intensive care unit not really being associated with frailty, largely probably because of the goals of care for the patient not including going to ICU. So all of this leads to the sub point there in the key point that we're trying to talk about here, which is that if we don't think about frailty, then we'll tend to underestimate the vaccine effectiveness benefit of vaccines, because we have a systematic bias here. Usually when it comes to vaccine studies, we talk about a healthy user bias, which means that the healthier people are paying more attention to their health and tending to do these health promoting behaviors. However, in this case, we have a frailty bias, which is the opposite. So the people who are most likely to be vaccinated are the frail people. And they're also, through pathways like immunosenescence and the inflammation that we talked about off the top, more likely to have a suboptimal vaccine response and be more vulnerable to adverse outcomes. So if we don't take that into account, we will tend to underestimate vaccine effectiveness. So that was the first key point. The second one is that the burden of influenza is usually considered in this short-term, say 2-week time frame, but we really need to consider longer-term impacts, both because it's relevant for the person themselves and their family and their quality of life, and also from a systems point of view, is very relevant when it comes to planning and paying for things like home care and long-term care. So in the geriatric literature, it's well known that when people go into the hospital, they can have different functional trajectories. So this study illustrates that point. So at the time of admission, the patients, say 43% of them had a decline in their function when they presented, say, to the emergency department. During their hospital stay, some of them recovered function, some of them stayed stable in their lower level of function, and some of them declined even worse, such that by the time they went home, about a third of them were worse off in terms of their function. And that is something that's really important for us when it comes to influenza as well, because what we don't want to see is people being admitted to hospital and leaving worse off than when they came in. So one way to look at that is through measurements of their function. And here we use a tool called the Frail index, which is a index of independence in 10 basic activities of daily living. And these are things like bathing, dressing, going to the bathroom, and walking. So they're very basic. It's nothing as complicated as doing your finances or cooking, anything like that. So what we found was that older adults hospitalized with influenza do suffer a significant burden of functional decline. And in fact, when we looked at a definition of catastrophic disability, which would mean complete loss of independence in 2 or more basic activities of daily living, that's anything that's more than a 20-point decline in the Frail index. What we found is that about 15% of our older patients in our network were leaving hospital with this catastrophic disability. And that is something that can even be persistent in the long term as well, and has these important impacts on their quality of life and their living situation. Which leads us to ask the question whether influenza vaccination may even prevent or delay nursing home placements. Because of this incomplete functional recovery, some people will need care to be increased, either from informal sources such as family and friends, or through formal paid home care, such as that provided through various provincial services that vary by jurisdiction, or even a long-term care or nursing home admission. All of these, particularly long-term care, has really important ramifications on a personal level as well as health systems levels. So what we really aim to do over the longer term here is to understand the impact of influenza on function so that we can see whether preventing influenza helps to prevent some nursing home placements. So in fact, in some early analysis that we have done, we have found that people with influenza laboratory confirmed in our network were just as likely to end up going to nursing home as people who came into hospital without influenza, which really does, and that there were some people who ended up transferring to nursing homes who didn't live in a nursing home before. So that's suggesting to us that some nursing home placements may be avoided or delayed if we're able to prevent that influenza hospitalization in the first place. So we'll certainly be doing more work on that within our network. We did another piece of work called the EXACT survey, which was looking at how community-dwelling older adults think about influenza and influenza vaccination and what matters to them. And we surveyed 5,000 of them in an online survey. So of course, this tends to be a fitter community-dwelling group that wouldn't include people living in nursing homes or people who weren't internet savvy. So of course, the generalizability will have its limitations. So one of the interesting things we included in that survey was the clinical frailty scale, so they could self-rate their frailty level. And we asked them whether they had the vaccine in that season and whether or not they had gotten an influenza-like illness, which we defined quite specifically for them to get as close to being sure that it was influenza and not something else. So of course that's a limitation because we don't have any confirmation with laboratory testing. So 21% of them said that they had had an influenza during that season. And of the ones who had the flu, 20% said they were not able to do certain activities of daily living while they were sick. Interestingly, 4 out of 10 of them said it took them longer than the usual 2 weeks to recover. And a subset said they never fully recovered. And we can all think of anecdotes of people that we've met who've had this happen to them, where they got an acute influenza and really ended up dragging them out and affecting their energy and function going forward. And the things that we found were independently predictors of this persistent decline in health and function were older age, having memory loss, and also having had the influenza or ILI, influenza-like illness. So the next key point is that older adults may not present with classic symptoms, which really has implications for the diagnosis and also management, but surveillance as well. So let's talk a bit about that. So in order to do surveillance for influenza nationally and internationally, various definitions have been developed. So a commonly used one is the World Health Organization influenza-like illness definition, which says that a person must have a measured fever over 38 degrees and also a cough, and it's come on acutely in the last 10 days. Now, we also looked at another definition, a case definition called of severe acute respiratory illness, SARI, which is similar but a little bit different. So it's also acute, having come on within the last 10 days. It has either a history of measured fever or a history of feeling feverish, so not necessarily a documented fever. And it does have a cough and requiring hospitalization. Now, of course, when we test these in our network, everybody's in the hospital to begin with. So both the ILI people and the SARI, they're all in the hospital. But what we did was recreate these case definitions within our data to see how many of our older patients presenting in the hospital would have been triggered by these ILI case definitions or the SARI case definition. And importantly, when we talked about the enrollment criteria for our network up front, I mentioned that we weren't limited by a very narrow case definition. We, in fact, were quite broad, thinking about any respiratory exacerbation. They didn't have to have fever, or if they did have a fever, they didn't have to have a respiratory symptom, because we wanted to make sure we captured as many people with influenza as possible. So when we looked at this, what we found was that the sensitivity or the percent of patients with laboratory confirmed influenza that we would pick up using this ILI case definition was only 44.6%. And this compares with younger adults without any high-risk conditions. It would have picked up 57%. So there's a systematic under-recognition of the older people if you use a narrow case definition like the ILI. When we operationalized the SARI case definition, it was a little better. So we picked up 57.1% of our older patients, compared with over 70% of the younger patients without a high-risk condition. So really, relaxing the fever criteria does help to some degree. We're still not picking up as many of the older adults in surveillance, which has important ramifications. If we were looking at surveillance reports from different countries, and they're using a narrow ILI case definition, we can be pretty sure that the estimates are going to be underestimating the burden of influenza, particularly in the older, frail population. So now getting to the next key point, what can we do about this? So what vaccine products are available for older adults, and what do advisory bodies recommend for their use? And I've included this reference to our review paper that I did with some very smart collaborators this past year, if anybody's interested in the details. So the general approaches to improve an older adult's response to vaccines, because of what we talked about at the up front about the immunosenescence, the changes in immune function, and the inflammaging, or the changes in inflammatory regulation. These are the ways that have been suggested so far. One strategy is to increase the dose of antigen. And the hope there is that it would better stimulate these adaptive responses and get better antibody titers and potentially cell-mediated responses too. Another one is to add a chemical agent called an adjuvant, which generates some inflammation at the site where the vaccine is injected and is meant to stimulate the innate inflammatory response, that non-specific responses. And it's meant also to enhance the ability of the dendritic cells in the immune system to present the antigen to the T cells and get better responses that way. A third strategy is to use recombinant antigens, which is just it's a different way of making the vaccine, for example, not using egg adaptation, but for example, perhaps using insect cells or some sort of cell culture. The ultimate goal that everybody wishes we had is a long-lasting universal vaccine that wouldn't be so strain-specific and would would last more than one season, so we wouldn't have to be giving vaccine every year. Now that's a longer term goal. So to touch on the first three strategies there, there's a high dose vaccine that's available. It contains 4 times the dose of each of the antigens. So in a traditional flu vaccine, they tend to be a trivalent or quadrivalent, meaning that they have an H1N1 antigen, they have an H3N2 antigen, and a B strain, or in the case of a quadrivalent vaccine, 2 B strains, or 2 B lineages that are represented. And these are decided based on the expert contributions through the World Health Organization coming up with a recommendation for which strains they feel are most likely to be circulating in the coming influenza season. But of course, that can be a very tricky thing to decide. In any event, the high-dose vaccine contains 4 times the dose of the antigens, and the idea is to target a more robust immune response. And when that's been tested, it's been found to have a relative efficacy, so we're back to vaccine efficacy because it was a randomized trial, of about 24% versus the standard dose. So it performs 24% better than the standard dose. And that's been fairly consistent across different studies, including cluster randomized trials in long-term care. In that case, they were finding reduced hospital admissions with respiratory illness overall, not even just lab-confirmed influenza. So that's the high-dose vaccine with a relative vaccine efficacy of probably 24% benefit over standard dose based on current evidence. The adjuvanted subunit vaccine includes this adjuvant, which is an oil and water emulsion designed, as I mentioned before, to potentiate the immune response. There haven't been any randomized controlled trials comparing adjuvant to standard vaccine, though there have been a number of observational studies in the real world where they've been given to, say, one group of nursing homes and not to another, finding increased effectiveness, preventing lab-confirmed influenza, hospitalization, influenza-like illness, and admissions for coronary for heart attacks and strokes. There haven't been any head-to-head comparisons either of the adjuvanted versus the high-dose vaccine. It's important to mention. So there are other vaccines on the horizon as well. So one of them is a recombinant subunit vaccine that's already approved in the U.S. For adults over 50. These can be, as I mentioned before, grown in insect cell lines as opposed to requiring egg adaptation. And part of the theory here is that in the traditional way of growing influenza vaccine in eggs, there are some changes in the strains that happen once they start growing the egg that may lead to important differences from the real life circulating strains. And so the vaccine effectiveness may not be as good once you get out into the people in the real world. So the studies looking at the recombinant vaccines have demonstrated that there was some benefit versus standard vaccines. So when it comes to the advisory body statements about influenza vaccines, in Canada we have the National Advisory Committee on Immunization, which goes through and does a very comprehensive literature review of all the evidence. And what they've said is that trivalent influenza inactivated vaccine and quadrivalent vaccine, which is the difference is the extra B lineage there, and adjuvanted trivalent vaccine and high-dose trivalent vaccine are all approved options for older adults. And they say that based on available evidence, they conclude that there is evidence that the high-dose vaccine should provide superior protection compared with standard dose for older adults. And this extra benefit appears to increase with increasing age over 65. They have a distinction between individual level and programmatic level recommendations. And they say that at an individual level, they recommend that high-dose vaccines should be offered over standard dose, preferentially to people 65 years of age and over. And that there's good evidence that it should be protective, especially against H3N2. Now, they don't make a programmatic recommendation because that's a tricky thing, telling a province or a jurisdiction that they need to spend their money in a certain way. That's something that tends to be left more to the jurisdictions to think about. And in fact, in Canada, there are important differences between provinces, and certainly this is the case globally as well, where different jurisdictions make decisions about what they want to be covering or including in their programs. So in the US, the Advisory Committee on Immunization Practices, the ACIP, they have a statement that lists trivalent and quadrivalent standard dose or high dose or adjuvanted or unadjuvanted or recombinant vaccines as potential options. They do not have a preferential recommendation for any of the products. In Australia, their immunization handbook states that high dose and adjuvanted vaccines are both preferentially recommended compared with the others, but they don't express a preference between those two. Now, importantly, in Europe and the World Health Organization recommendations, they do not suggest prioritizing one product over another, and they do make comments on availability because these products may not be available in many countries, especially lower middle income settings. I like this quote from the US ACIP because they really come back to the pressing need to improve vaccine coverage and say that vaccination should not be delayed if a specific product is not readily available. So if you've got someone in front of you and they're willing to have a vaccine and you have an approved product, it's better to vaccinate rather than dither and say, well, maybe down the road we'll have a different vaccine that could be helpful. So hopefully that's been helpful to show how frailty is related to influenza. So first of all, understanding frailty is so important in identifying the illness itself with these atypical presentations and measuring vaccine effectiveness, and that we really need to be understanding the impact of influenza on frailty and function in order to understand the true burden. So these slides come from my colleague, Janet McElhaney, who does such a great job of conveying this too. So she says, here she's got the person aging along the levels of frailty in the clinical frailty scale going down the hill towards worse frailty. But what we want is for people to stay stable or even improve their frailty level. And how can we do this? There are many different ways that have been looked at, and certainly there'll be more research in the future. But one way is to avoid preventable illnesses and hospitalizations, leading us to the concept of vaccine preventable illness and disability. So in terms of how this could impact practice, it's important to recommend vaccination for older adults across all grades of frailty and consider different products depending on the setting and availability. We want to be thinking of preventing influenza in people around them as well, so family members, caregivers, healthcare professionals, and doing the very important public health measures such as isolation, droplet precautions in hospital, and washing hands. Now, of course, you can't put somebody on droplet precautions if you haven't thought of the fact that they may have influenza. So again, that leads us back to this issue about how it's important to be thinking of it and testing people even if they don't have specific traditional symptoms. And we need to be considering frailty and function in research and surveillance and clinical practice. For anybody who's involved in surveillance studies or research studies, how to integrate frailty into those studies might be something that comes to mind. So there are many different frailty measures that exist, and I showed you a couple of examples. There are others as well. And importantly, even though it seems like the frailty index has a lot of different data points that would be labor intensive to collect, a lot of studies do collect a lot of these data points through their usual protocols. And so it may well be possible to even generate a frailty measure retroactively. And we have looked at that in this publication that I list there in a vaccine trial if you're interested. So here are some resources that can be helpful, particularly these are the Canadian ones. Immunize Canada is a very important group, and I'm sure the IFA will have links to them. So to put it all together, I'm quite a fan of this idea that critical incidents or adverse outcomes happen not just because of a problem at a single level, but it's really when the holes in this Swiss cheese line up. So when older adults, if we think about them as being the farthest along here, the frail older adult will have bigger holes in their vulnerability. And so we can work with them to try to improve their frailty and plug up those holes. But we can also protect them upstream. So an older person is vulnerable to these outcomes. They have more complications from influenza, but they don't tend to be diagnosed as well because they have these atypical presentations. So then, therefore, we don't treat them, and they don't get the benefit from treatments that could be helpful. And upstream from that, they're more likely to be exposed, for example, in institutional settings or from healthcare workers who are sick themselves. And they're more likely to get sick. So we really want to be targeting our response to protecting older adults at all of these different levels. And with that, I'll conclude. Thank our various funders and important team members. And I'll be happy to take any questions.
Dr. Andrew, thank you for that very insightful presentation. It was certainly insightful for me, and I'm sure for many of the people listening in on the webinar. Your research and work in the field truly speaks to this year's IDOP theme, the journey towards age equality, and I want to thank you for your presentation today. There has been a couple of questions through, and I will pose some of those to you now that you might be able to respond to. And particularly, you mentioned earlier in the presentation about the scales that are being used around frailty. And one of the questions was, are they recognised and used in other countries other than Canada?
Yes, so the frailty index has been used widely around the world in many different settings, the clinical frailty scale as well. In the literature, though, you will find that different research groups in different countries have developed different frailty scales. So it may well be that your setting has a scale that's widely used in that particular setting. For example, there are some Dutch ones, there's some ones from Quebec. So really using any validated frailty measure would be a step forward.
Okay, all right. And following on from that particular question, there was one particularly around the issue of diabetes and whether a person with diabetes is going to respond, should be vaccinated, and what's the recommendation for those with diabetes in this case?
Yes, so diabetes is considered a high-risk condition, so getting a influenza vaccination would be important. There would be various studies done, by immunologists looking at how diabetes itself affects the responses to vaccination, which is beyond the scope of what I can touch on. But I think safe to say that the main point is that someone with diabetes would be at higher risk for influenza and complications, and it'd be important to have a vaccine. Okay,
thank you. NACI in Canada also assesses the quality of data available for each influenza vaccine. Do you think it's an important factor to take into account when choosing an influenza vaccine? So whether it's from a patient's point of view or an individual's point of view or a physician's point of view.
That's a great question. Definitely, NACI does have a very rigorous evidence evaluation process, and they publish the results of those, and they're available online for those who are interested. And so I think it's quite a reliable source, really, to look at the recommendations from NACI and think about how they apply to oneself or one's patient population. There is that distinction that I mentioned between an individual level recommendation and a programmatic recommendation. And the individual recommendation in this case for older adults is that the high dose vaccine appears to be more beneficial than the other vaccines and should be offered. Now, that's something that people would have to decide based on availability locally and what's covered through their province and what's available in their pharmacies and whatnot, even if it's not covered. From a programmatic level, they haven't made that recommendation, and again, that speaks to the complexity of decision making and weighing pros and cons on a systems level. Now, there have, of course, been studies that have looked at cost effectiveness of the different vaccine products, and some of these studies will show, in fact, that the vaccines are cost saving, even if they're higher in cost for the product itself, because it prevents that many more adverse outcomes, hospitalizations, and other things that bring expense, then they tend to be finding that they're cost saving. That's something that one could look at as well. But definitely going back to the point that the NACI recommendations are really well considered and are excellent sources of information for people and healthcare professionals.
Thank you. It's interesting that, you know, funding for the high dose influenza vaccine for those over 65, I understand, would cost less than 15% of the cost for those that might be hospitalized due to influenza. So it really is a significant saving. And I think the important thing, and you raised it early in your presentation, is trying to link this information back to functional capacity of individual and how that potentially declines with influenza. And in many cases, people don't get that functional capacity back to the 100% that they had prior to the influenza bout. And for those that are on the webinar, just a little bit of history to finish and before we wind up. So in 1900, only one vaccine was widespread for use in North America, and that was a smallpox vaccine. That one immunisation contained roughly 200 molecules that provoked the immune system and created antibodies, and they were all antigens, in other words. So you'd think today that, to think that today we can protect against an astonishing 14 diseases by the age of 2, there'd be more, and the immune system would be working harder. Well, this is not right. Thanks to advances in vaccine technology, vaccines are not only safer than ever before, but they require fewer antigens to be effective. In fact, the entire childhood schedule now only contains an estimated 160 antigens, far less than many of us on this webinar would have received throughout our life. So it's a fascinating change in terms of how vaccines have improved the quality of life for older people across the world and increased longevity. So I'm going to just finish by talking a little bit about the IFA's Global Conference, which is taking place next year. It's the 15th Global Conference, and the theme will be Rights Matter. And the focus really is on the rights of older people, that they are human rights and need protecting. So registration is now available and open for that conference, which is on 1st of November to 3rd of November, and the website is ifa2020.org. And finally, I want to mention that prior to the conference, people can also attend a Vaccine for Life Summit, which will be on the 31st of October, and the summit will bring together experts, thought leaders, decision makers in immunisation to understand the public impact on vaccine preventable diseases, inspire change and galvanise action. So registration is available for that. And I think there's an onus on all of us on this webinar to look at how all of us can contribute to trying to improve the uptake rate of vaccines, particularly for older people, because it is life-changing. They contribute to healthy ageing, prevent hospitalizations. And with that, I want to thank all those participants for attending today. Let you know that you'll all receive a copy of the webinar via email, and also some additional information in respect of events that are taking place in the near future. So with that, I want to thank again Dr. Andrew for your excellent presentation, and to all the participants on the webinar, have a great rest of your day. Thank you.